All right, well, welcome everyone. Thanks for joining us for this webinar today. I'd like to just start by acknowledging the traditional owners of the land that I'm joining you from, the Kaurna people, and acknowledge their spiritual relationship with the land that we meet on. Pay my respects to their elders past, present, and emerging, and welcome any other First Nations people that might be joining us across Australia and New Zealand. Welcome everyone. I think we have about 200 odd registrations for this webinar today, and I guess this is part of a series of webinars that we've been running over the last few months to really bring people with experience and expertise around a range of topics with groups and health services that we've been working with across public and private healthcare in Australia and New Zealand. So the topic today, to make sure you're in the right place, is elective surgery optimisation. We'll talk about what is that, why is that topical now, and why is it an area of focus for a number of the health services we're working with. We'll go through a round of introductions to the panelists. I'll ask them to introduce themselves and their interest and experience in this area. We'll look at some of the traditional options available to health services around optimising elective surgery, and then look at what I like to call some of the lifetime options. So what are some of the options that might be realistic in the short term, and some of the experience that the panelists have had. And before I go too much further, I guess really keen to make this an interactive session. So very keen to have the audience participate in putting questions to the panel members. So feel free to, if you've got a question, a comment, or an idea that you'd like to discuss, please just put it into the chat function, and we'll take that and put it to the panelists as we go through. So I'll just spend literally a couple of minutes here just introducing who we are as an organisation. So my name's Ken. I'm the CEO of a digital health company called Personified Care. And our mission and our reason for being is to connect patients to the care and information that they need in the lead up to an admission into hospital and their transition back into the community. So we work with public and private health services across Australia and New Zealand to essentially convert their clinical models of care into what we call digital patient pathways. And so a lot of the work we've been doing recently has involved working around elective surgery optimisation pathways across various parts of that patient journey. And we've seen all sorts of different flavours around what that's meant, different nuances around how that's been applied in private and public settings. And so we thought this was an opportunity to just bring some experts from different parts of the health system, different regions, different perspectives, and really flesh out what's happening on the ground in various areas. I guess just to sum up from our perspective, what we've seen in our experience of the last 9 years is really to move the needle on anything in healthcare. You've really got to do three things at once. You've got to somehow improve the quality and access to care for patients. At the same time, you've got to also reduce burden on staff. And in the process, you've got to improve the sustainability of the system from a financial or other perspective. And so that's really what drives most of the work that we do with health services. So that's enough about us. I'm going to hand over back to the panelists and just ask them to introduce themselves, a bit about their role and what's their interest in elective surgery optimisation. So Laura, you work for Austin Health. Your title says you're the workstream lead of elective surgery reform. So I guess you have some interest in this space. Welcome, Laura, if you'd like to just introduce yourself.
Yeah, thank you. Yeah, so I've worked at Austin Health now for over 17 years. My background is acute surgical nursing, and I've worked in sort of various senior nursing roles within the division of surgery and endoscopy in that period of time. I've also done some quality, safety and risk management, and I'm currently working, as you said, as a workstream lead for the elective surgery reform unit at the Austin.
Excellent. Thanks, Laura. Casey, coming to us from the Barossa Hills Fluoro Local Health Network. Welcome.
Thank you. So yeah, my name's Casey. I'm working within the Barossa Hills Fluoro Local Health Network, and our network serves 41% of our regional population in South Australia. And we border all four of our metro LHNs as well. My background is as a registered nurse, and I worked in the operating room for a long time, and then moved out to an elective surgery space.
Excellent. Thank you, Casey. So I'd be interested to get your perspective on how how this area is being looked at from a regional perspective as well. Stuart, so you're coming to us from New Zealand. Spent some time there over the last couple of years across both public and private setting as a consultant. Welcome.
Hello, hi. So I'm Stuart Burrows. I've basically been in New Zealand now for nearly 2 years, and I've begun to get involved in the head and neck network planning for our region of New Zealand. My other background from the UK is I spent 3 years working on integrated care pathways in the east of England, and trying to do essentially what we're talking about, which is just to try to optimise patient care on a sort of patient and clinical footing.
Excellent, thanks, Stuart. So look, I think this is probably familiar to everyone in their audience, but why now? Why elective surgery optimization? This picture is familiar to probably everyone on this call. That post-COVID, there's been a huge uptick in people waiting for elective surgery or planned surgery, as it's called, and there's been some progress made at different stages, different jurisdictions to try and accelerate the recovery, if you like, on those waiting lists. But it's pretty clear that we've got a long way to go, and we've certainly been watching work in terms of expanding bed capacity in the public sector. That requires more staffing levels, which is a challenge to say the least at the moment, given the demands on doctors and nursing workforce across a range of different settings. And in some cases, we've seen public health services contract out procedures into the private sector. I guess the challenge that we see across the board is that most of these traditional options will take some time. So you can't open up bed capacity overnight. You can't. A recruitment drive for extra nurses and doctors is going to take some time. But the question is, what else are we going to do to address this gap and catch up on these waiting lists post-pandemic? And I guess that's where I wanted to start to open it up to some of the panelists around what are some of the initiatives that you're seeing within your health services or that you're directly involved in, and what are you seeing that's working, that's not, and perhaps take the discussion from there. So Laura, I'm going to throw it to you first, if that's okay, given that that's front and center of the work that you're doing in your work stream on Austin. Perhaps you can just tell us a bit more about your role. What does that role, what's elective surgery reform mean in the context of Austin and the work that you're doing, and what are some of the initiatives that you've picked up there?
Yeah, no worries. So I guess, as you mentioned, post-COVID, we had the blowout of our elective surgery waiting lists in Victoria, and at the Austin, we saw a growth of approximately 188%. The funding was given to all the major public hospitals to set up these elective surgery reform units to work together on initiatives to improve our waiting lists. And the Austin forms part of the Northeastern Health Partnership. So we're working with hospitals in our region and collaborating on what sort of initiatives we can put together. And predominantly the work we've been doing has been about increasing our day case rates. So 2 of the initiatives we've rolled out recently, one we launched on the 1st of April was a hospital in the home pathway, and that included a pathway for complex or large hernia repairs, hemorrhoidectomies, and adult tonsillectomies. And that was really about not so much reducing length of stay, because hospital in the home admission days are included in a length of stay, but reducing acute bed days. Our other initiative was our day case. We rolled out a day case surgery pathway that includes laparoscopic cholecystectomies and small hernia repairs. And that really is to reduce length of stay for patients. And that launched on the 1st of June. So we are still in the initial phases of recruiting and putting patients through the pathway.
Great. Thanks, Laura. It sounds like some of those initiatives are, looking at some of these things from I guess both ends of the spectrum, both really acute patients, but also some of the lower risk patients, and trying to fast track those patients.
Yeah, and look, it's just to get these sort of pathways set up. What we found was that our starting point was speaking to patient-facing clinicians about what was working well in day case models and tools and what wasn't working so well. We also found getting key stakeholder to get buy-in basically from our stakeholder group. We had to find a single point of contact within those units and each craft group with the time and interest for this kind of work to get a pathway drafted and then rolled out. So that wasn't always necessarily a head of unit, but sometimes it was a senior clinician with interest in that particular area. So that was what worked well. And then we had to set up our own governance committee. We wrote a protocol. It went through all the appropriate committees throughout the hospital to get approved. And we then are continually monitoring the success of our pathways. We look at pathway failures, why they occur. We're looking at readmission rates, representation to ED within both a 24-hour and 28-day period. As well as getting feedback from patients on any new pathways, on what's sort of working well, and then continually learning from that.
Yeah, great. And we might come back to that kind of continuous improvement kind of cycle on how you actually build that into the system. Casey, I might just throw to you. I'd imagine that as pressure builds on some of the metropolitan hospitals that demand for elective surgery or some of that work starts to get pushed out to the regions even more so. Is that been your experience, and how have you kind of attempted to deal with that from a regional perspective?
Yeah, absolutely. I think for us, we've been involved in some discussions statewide about the capacity and the demand within the system, and where we could possibly transfer patients to assist with some of that recovery. There are, of course, challenges in that process as well. Being a regional site, we have visiting medical officers, so we have limited capacity within our theatre scheduling. So it's been discussing those elements with our surgical services teams, trying to review the current utilisation within the peri-op space, and doing some quality improvement there, so we can then utilise some of the capacity that we might have. But yes, that has been a little bit of a challenge. We'd absolutely love to help as much as we can, but I think there are lots of elements involved in that, and lots of challenges along the way. Certainly because we are regional areas, we don't have the ability to treat the higher acuity patients. So often that is the lower acuity that we're looking at. But there are some other initiatives happening within the state in terms of assisting recovery with the private providers, and often that's the cohort of patients we'd be looking at as well. So some of the challenges there in that.
Great, thanks, Casey. So I think that's an interesting point around visibility to capacity across the system, and where there is capacity to care for some of these patients, and how you within your own region have visibility to capacity across the system. And I guess the other point we might come back to is also how do you actually get visibility to the acuity of that patient when they've been on the waiting list for a while. Stuart, I'm keen to get your perspective, given you're working both across in New Zealand, across both the private and public setting, and also perhaps what have you seen compared to some of the work you've done in the NHS in the UK, and how does that compare to what you're seeing in New Zealand at the moment?
Everywhere in the world seems to be in the same situation, with particularly post-COVID. I mean, everyone was pretty close to 100% in the public health systems prior to COVID, and then COVID hit, and just every plan we had in place just got slightly parked, and everyone was in survivorship mode for a few years. And now it's been, how do we recover that? And I think, and points have been put, is how do we essentially load spread our systems? I mean, that we know that there are some hospitals that may have a bit more capacity than others. The biggest challenge is often communication, and it's making sure you've got the right patient, having the right operation in the right facility to get the best outcome. And that takes a lot of challenges. And the work that we did, I mean, it's been mentioned, is, do you need the patient in the hospital? Could they go to essentially a sort of hotel nearby, but have access to get back to the hospital if they're a distant patient? And that works well for your 23-hour stays because of distance lived from the hospital, to the other extreme, which is looking at your sort of enhanced recovery programs and your prehabilitation of patients in the run up to major surgery. And all of those revolve around developing a pathway that can distinguish the patients who are going to do well and do badly, being able to gather that information to the decision makers, and then figuring out which facilities are most suitable for those patients to be treated at. And that may be outsourcing to the private sector. That may be, utilizing more district general style hospitals rather than your major teaching hospitals. And that leads to you not having late cancellations, and late cancellations cause a lot of chaos at times, and is trying to maximize the facilities, both infrastructure and personnel that you can. So certainly from our perspective, our role was trying to look at, could you change that 23-hour stay into a day case? What was preventing that from happening? Was it geography, in which case local sort of de-escalation units, so hotels or other facilities nearby was one of them. And also, could you get your very long stairs who occupy a huge number of bed days and actually prevent you doing an operation because you haven't got a bed rather than because you haven't got a theatre? Could you reduce those long stays? And that's actually the pre-op optimisation pathways that people are developing. And then it's how do you get all of those linked into a system where it's visible to those trying to place those patients. From our perspective, everything was based around essentially is communication pathways, and that is essentially medtech. The days of sending faxes in the NHS and lots of phone calls and huge numbers of staff liaising with another huge number of staff and another huge number of staff liaising with the patients isn't a genuine reality with the numbers we're dealing with. And that's I'm very hands up about the benefits of how medtech's enabled us to be able to visualize and look for opportunity, which we didn't have before.
And yes, Stuart, I think that's really interesting, because that reminds me of the old adage that the future's here is just not evenly distributed, right? A lot of the groups that we work with are still, that is their reality today. We're still using letters and phone calls to capture that information. And I guess that's perhaps kind of drilling into that patient journey. Perhaps I'll kind of look at one of the areas that we start with is how do you actually get visibility to your actual wait list, both in terms of size of that wait list, the level of acuity, and particularly when, post-pandemic, when some of these patients have been on the waitlist for extended periods of time, their acuity may have actually changed over that period, right? So getting interested in some of your thoughts on within your existing roles, how you're managing that, how do you get visibility to those patients on the waiting list, and the interesting dynamics between what that looks like from an individual hospital side to a health system to statewide, and how that's all coordinated. As you say, it's a challenging set of...
if you look at what we did in COVID, was essentially write to everyone and say, you're on our waiting list, please tell us if you're in trouble. And it was that ridiculous, is writing thousands of letters to lots of people and hoping they're in the residents that we'd sent the letter to. I mean, it has got a lot more nuanced, and there's now a lot more people using apps, telephone, text to communicate with patients. And some of the things that we noted that made a huge difference was actually just making sure the patient didn't think they'd been forgotten. And actually, that's where I think the ability to have an interaction in the digital world is quite useful, because it means it frees up a lot of your admin time. And that's been, I think, a big win for where we've been able to implement it in ways. I mean, there was always this sort of feedback that, what about the group of individuals that don't use technology? And that was normally referencing the retired age group. Actually, they're far more technologically advanced than anyone thinks. I mean, all my parents and my in-laws, they all Skype and Zoom my kids. And they're far more aware of all these platforms. I think the worst are probably people my age. I mean, we're sort of in that middle ground where almost in denial. And I've been really surprised at every patient group I've approached that I thought might not be as tech savvy. They've really surprised me, saying, yeah, we're very happy with that. I thought I haven't found the resistance I thought I would get.
Yeah, sure.
So as I say, that's why I've got quite a buy-in.
Yeah, and sure, I think a lot of the data we have around adoption of technology certainly supports what you're saying, is that older demographics, as long as you've got something that's as easy as social media or text messaging to use, then they'll readily accept it and use it at a high rate. And I think one of the when we discuss it as a team internally, one of the upsides of the pandemic was that health services started to realize that their patients actually can engage with technology, and that's across all demographics really. And I think you're right. I think perhaps it's that age group in the middle that's perhaps a bit less or more attention for, if you like, or time for, and sometimes they're the hardest populations to reach. Casey, I'll just throw back to you, perhaps just in terms of that, your experience in a regional setting around how you get visibility to, who's on your wait list, and how do you go about doing that traditionally, and what some of the initiatives you looked at recently on that space, and what does that mean to you across a whole range of different hospitals?
Yeah, absolutely. So our referral process is out to private rooms, and then they're booked then into our operating lists. So certainly our patients are going to see local GPs and then a specialist. We were finding gaps between the assessment that was made in those areas, then coming through to the hospital. In many cases at our different hospitals, it was a different workflow and process at each hospital. So it's just identifying that we had a gap in the way that our information was coming into our system. We didn't have great visibility over those patients that were on the wait list that hadn't dropped their paperwork off. So we could then add them to the wait list, and then just that closing that loop with an anaesthetic review or a surgeon review. So we had in the last 12 months implemented some digital pathways for our patient admission, and offering that patient choice to use that digital platform, because we were quite concerned about some of our older populations, and providing that choice to them to use that digital platform or remain on that hard copy pathway. We don't have an EMR within our LHN, so it certainly was very paper-based. The other thing that we did identify is our patients were travelling between all of those different areas to receive an assessment, to be booked onto a wait list. Then they were coming into the hospital to drop their paperwork off. So we really felt that it would be beneficial for our patients just in terms of their access to care, how they were receiving the information that they required, because often from our perspective, it was hard to give them that consistent communication as well. So we've been able to implement a digital pathway that allows us to communicate what we need to the patients, and we instantaneously get the information we need from them about their admission. So that certainly was a challenge, and we feel like we've been able to assist our patients to receive a higher quality of care by enabling that process.
And Casey, there's just been a question in the chat that kind of ties into your comments just now, just directly. I think the question is from Lee, thanking everyone for their time, and she's asking, she is asking whether anyone's crunched the numbers on the improvement in patient experience, numbers of patients seen, and I presume this means whether there are any additional staff needed in the context of applying these pathways compared to the old model. Any thoughts on that, case?
Yeah, absolutely. I'll start with, I think the last part of that was staffing and training. And yep. So what we did find that the staff were a little bit hesitant at the start because we don't have an EMR and everything was on paper. There was a little bit of reluctance there and a concern about the patients that would be using the pathway. We found that staff were able to upskill really quickly. We involved them in all of those discussions around the workflow, the pathways, making sure it suited their current workflow, not trying to change what they were doing. So in terms of training and workforce, it was something that was pleasantly surprising in terms of the way that the staff were able to use that and then support the patients to use them as well. And just in terms of numbers, we have 73% of our patients will use our pathways now, and we still do have a cohort that will come in and do that hard copy process. Was there another part to that question, Ken?
Have you measured the patient experience? And perhaps I'm trying to interpret the question as well, but did you need additional staff, I guess, to support this process as well?
Yeah, we didn't need any additional staff to support this process. What we did was, as I said, communicated and consulted with our teams, and then we were able to put the pathways in as we needed. In terms of patient experience, we're able to collect really good feedback on patient experience that we weren't able to do before, because before we would have had to contact patients, send out surveys, ask them for that feedback, whereas they have the opportunity to fill out that feedback immediately after their procedure and have that sort of feedback loop with us. The other thing that has allowed us to do, just in terms of workforce, is think of new ways of working. We've got these lovely pathways set up now, and it gives us the opportunity to think about other things that we might be able to do to improve the process, improve our workflow, and efficiency. So that's been an added bonus on top for us.
Thanks, Casey. So Laura, I might just switch over from your perspective. It's interesting to hear you talk about how Austin's collaborating with a number of health services in the region. And one of the threads in the conversation so far is about, sharing information is key to solving some of these problems. How have you in your role, or how's Austin thinking about sharing information across those health services within Victoria in particular? And any thoughts on that in particular around the projects you're working on at the moment?
Yeah, so I suppose tonsillectomies is a pretty hot topic at the moment, and they've our Northeastern Health Service Partnership Director has put together an ENT networking group, for example, to discuss, what are the barriers to doing paediatric day case tonsillectomies. And there's lots of barriers that come into play for that particular surgical procedure. And then there's what we've found is lots of variation in the models of care. We're all trying out and designing, and then feedback to each other about how things are going. And so for us, we've put together an adult tonsillectomy model of care with HIF, but the plan is to eventually, if the results of that and the readmission rates for that are low, we'll transition that to a day case model of care. So we're using that networking group to share ideas about pathways we've put together as a starting point. There are some hospitals that are further ahead with the development of their pathways, and then it gives us a starting point with our surgical units. Well, this is what the Northern's doing, for example, in laparoscopic cholecystectomies. This is their data so far, and it sort of encourages, I think, sometimes the surgical units to get on board to pilot some of these cases. So I hope that's an option.
Yeah, thanks, Laura. I think that's really interesting. Stuart, any comments on that around how, particularly in the context of a surgical waitlist, what you've seen different parts of the health system, how you share information across different parts of the health system, and whether that does or doesn't work, and everything in between?
And I think one of the problems is there's always an inherent resistance to change. That we just have to face that. It's everyone's comfortable with where they are often, interestingly, you brought up the thing on day case tonsillectomy. It was something that we worked on quite hard, and there were varying factors that were causing holdback. One, it was distance. Others was perceived potential risk. We're very fortunate in the UK that there is quite a robust document on what should and shouldn't be day case, and that was always our starting point. And then it was within that, what could we modify? And I think I mentioned not going home, you're going to a local sort of hotel if the distance was too long. Were there ways we could deliver the anaesthetic that may make them quicker to recover? Did we have things like the optimal pain relief pathways? Had we got everything lined up? And then the thing that really seemed to make a difference was patient expectation. The minute you said you're a day case patient, they're almost upset they're not going home. If you had the default that they were staying overnight, but we might let them go home, the expectation was they'll be overnight. And that was also something that was the way we tried to approach it with the staff, and the way that we presented everything was utilizing that as a model. Now, moving on from that, one of the things that, again, the NHS has been putting into place is a thing called GIRFT, which stands for Get It Right First Time, which is exactly what Laura's been mentioning, is where they look at what each unit is doing and can we identify best practice by comparing like for like units. And then they don't necessarily tell you what you need to do. They let you interrogate the data and try and come up with your own conclusions. And that's been used very, very well in orthopedics, and it rolled out in ENT and other specialties. And it was really, they came and appraised my unit when I was in the UK. And I was actually, there's a lot of things you don't think about. You're in your little bubble, you think you've got your own problems, you try and identify them. But when you see what other people are doing and you're going, well, how did you manage that? Once you've actually contacted them, there's often really low-hanging fruit you haven't considered. And the one I mentioned is decent pain relief. Tonsillectomies. One is telling the patient it's going to hurt a lot. Two is making sure that you gave them adequate pain relief and your readmission rates drop. And you make sure that the GPs are engaged with it, and your readmissions and your patient satisfaction just goes up. And a lot of that is just having systems in place. So certainly comparing units, I think, is a really good thing, and learning from best practice. And it certainly slightly opened my eyes to a few things we were doing when I was clinical director, and I found it really useful. I'm sure it can be a bit affronting at times. It's like, why aren't you as good as next door? But actually, I think most of us are. Your goal is to benefit the patients, and you've got to slightly take a step back and say, why are they doing well? Is there something that we can alter and change?
Yeah, Stuart, I just got a question here from Sue around some of the things you were saying around what were the strategies for those patients who had no one in their lives that could stay with them overnight at a hotel or something similar?
I mean, sometimes you're always going to have a social admission, and that's something you have to accept. I think with all these projects, one of the things that you get feedback is there's why doesn't it work for everyone? And the answer is it doesn't have to. I mean, even if you can streamline a process that benefits 40, 50, 60% of people, that frees up your staff time to concentrate on those that are, socially have a lot more problems, medically are more unfit, and it saves so much time day to day. And I think that's where but you've got to understand that you are going to have a cohort of patients who cannot, for social reasons or medical reasons, go home and turn around as quickly as you want. But that's what healthcare is about. You've got to be able to cover all your bases.
And I think that's certainly true of our experience in working with some of the health services, in that as they start to set up these different models of care and different pathways, one of the challenges they have is it doesn't mean that it's a one size fits all for all patients. That if you can, build into the pathways the screening processes that identify which pathway is appropriate for that patient and their level of acuity, then you can direct those patients to the best possible pathway for them. And some of the practical challenges that we're helping health services with is just collecting and triaging that information efficiently from patients when they've been on the waiting list for so long, given that their acuity or circumstances may have changed over that time. And I think that's one of the areas there's potentially a big opportunities. How do you link patients that are on a waiting list for a long time into preventative or rehabilitation models of care while they're waiting, so kind of reducing on the underlying risk factors by the time they turn up? Laura, did you have anything to say about that and some of the work you're doing? Is that did you want to comment there?
In terms of prehab?
Yeah, so I guess at a high level, the question is, some of the comments there around how are you managing around setting patient expectations, and how are you identifying which patients fit into which pathways, if you like?
Yeah, so I think, so for example, with laparoscopic cholecystectomies, I'll use that as an example because we had a surgical unit start this before our project actually started. They developed a day case model for lap cholecystectomies, and that had been going for about 6 months before we'd rolled out our day case pathway that included laparoscopic cholecystectomies. What we found within that unit was that after a period of 6 months, it became part of that surgical consent conversation. So the expectation setting started happening at that point in time, and it makes a huge difference. You're absolutely right, because if that expectation is at the time of surgical consent is that patient staying overnight, it makes that conversation of the liaison nurse who goes to book the patient X amount of time later a lot more difficult to turn that around. So what we found in that unit is now it's just become kind of standard practice that this is a day case procedure. And if it's not, well, it's a very good reason why it's not. And so we've had other surgical units start to come on board with this particular pathway. And we're seeing how that hasn't been integrated yet into that surgical consent conversation. So it can change the outcomes there. But yeah, and sorry, what was the second part you asked me there?
No, it was really just about setting that patient expectation, and I think you've answered it quite well. I'm just reflecting on some of the work we've been doing around this, and one of the advantages of developing some of these pathways is beyond the initial referral and consent and discussion is by screening the patient security as they're being assigned to a model of care or a pathway. One of the health services we're working with was dealing with this exact challenge. How do you manage the patient expectation on the way into a acute hospital? And depending on their level of acuity, they were being essentially, as part of their communication, being provided with information about their length of stay and the fact that this actually is best for in terms of their outcomes. And just that shift alone in terms of how different cohorts of patients are provided with different information means that by the time they arrive on their surgery, it makes a big difference to their expectation around the quality of care that they're being given. But there's not that perception that somehow the quality of care that they're being given is inferior because their length of stay is shorter. So I think Casey, I guess from your perspective, from a regional perspective, some of these things are probably even more acute or magnified because of the distance that patients have to travel to a hospital. Any other comments or thoughts on some of the things they're talking about in terms of setting patient expectations?
Yeah, absolutely. Because our patients do visit the other areas outside of the hospital to either be provided with information or provide information, then it makes its way to the hospital. With our pathways in a digital format, we're able to tailor the information that our patients need, and that then assists with their expectation of the service when they arrive. So previously, depending on the private rooms, they would have been given a certain amount of information, but perhaps not everything they needed to know. So we feel like we're providing information to our patients and setting that expectation, but then there's also the expectation across our LHN and the different hospitals and the way that they work, and providing that consistent message. So I think that certainly helps us in terms of patient expectation and experience.
Stuart, there's another question around how do you engage with VMOs to agree on standardisation? VMOs work with both public and private, and we find communicated length of stays from the surgeon is a lot longer than what we would expect. I'll throw that one to you, Stuart. That's okay.
VMOs, assuming vocational medical officer, is that correct?
Visiting medical officers in our Australian vernacular, yes.
Oh, visiting medical officer. Yep. So no, I one of the big challenges is the clinical body, because we often have quite rigid views on practice, and I'm very openly admit that can always be a challenge. Is if something's worked for us for 20 years, why would I want to change my practice that's been successful to date? A lot of it is around communication. It does take a lot of time to do the relationship building, and it is as much an engagement process between clinicians as it is as we have with any of our patients, and that takes time, unfortunately. I mean, yes, there are projects, as I mentioned, things like GIRFT, where the government comes in and states what best practice is, etc. But actually, as individual clinicians, it's often it is them developing trust in the changes you're looking to implement, and that's a biggie, and sometimes you won't be able to engage them as much as you would like. I do think in the post-COVID world, it's become easier to have those conversations, though, because things got thrown up in the air so much. We've had to adopt changes, and they haven't been disastrous. So I think as a result, we're a bit more open to change than we used to be now. And certainly one of the comments, VMO is highly engaged if it reduces cancellations. Yeah, and also one of the big things in terms of motivating surgeons and people like me is being able to turn up on the day and do our job and feel like we're doing what we're trained to do. And that is where I do think all these pathways make a huge difference. The biggest heart sink is having a patient turn up and then not be fit for surgery for some reason, or you not being able to do what you want to do. And that's the big sell in my mind to my colleagues. And when it was proposed to myself is you're going to do what you've been trained to do, and you're going to do what you enjoy, which is be a surgeon. And also the patient outcomes are good. So in the end, a happy patient that you've done a good job on it is the motivation. And you can't achieve unless the patient who turns up to be operated on is the right patient in the right facility. And that's how you sort of try and direct it, is you sort of move it up to the patient perspective and hope that you get engagement.
Gemma Moy was saying that on the live chat that they've obviously had some really interesting results by applying ERAS models of care that are in reducing length of stay without impacting readmissions, and that's consistent with some of the work we're seeing across health services we're working with. But in the process, you end up redirecting a lot of your nursing and clinical resources to that preoperative phase. And the flow and effect of that is essentially what Stuart was saying, is that you end up with patients that are better prepared for their surgery with a lower risk profile by the time they arrive, and less cancellations for visiting medical officers. I think the only thing I will add to that from our perspective is applying digital to this equation means that you don't have to necessarily have standardizations across all range of patients or across all specialists or VMOs. But digital solutions give you the option, and we've seen this practically, of hospitals and health services actually engaging with VMOs to have some input onto these pathways, where you can have variations of these pathways using digital solutions by specialty group or even down to the specialist, and then actually measure the outcomes of those things and let the data do the talking, right, across a whole range of these different metrics around length of stay, readmission rates, outcomes, patient experience, cancellations, etc. And I think what we've seen is introducing technology to existing pathways provides visibility of how these things are all performing and makes it easier to adjust those. I guess just quickly back to you, Stuart, if we've got you back in terms of the connection. Have you seen any differences in, and I'm sure there are, and we know there are, but what's your observations in terms of how this works differently in private hospitals versus public hospitals? There seems to be a big shift to, again, increased throughput in private hospitals for a whole range of different reasons that might be driving some of the publics. Any observations how the two different parts of the system operates in New Zealand from what you've seen?
Yeah, and I think one is the acuity of patients you generally put through the private sector will be different to some of the acuity you put through the public sector. And so therefore you do have more of an ability in the private sector to have a slightly more higher throughput lists. And I think having that ability to have dedicated high throughput lists is very good for turnover. And having a list with 6 consoles rather than a blend, it's just quick turnover. It works well. It's the same operation. And so the ability to standardize lists makes a big difference, and you can only really do that if you have dedicated high throughput lists. And actually that's what works well if people are outsourcing to the private sector. I think for me, in terms of how the preoperative setup works, is obviously I have much better oversight in my own patients than I do of an outsourced patient from the public sector, which again, why that communication is key. And it's a bit like the VMO coming into the hospital. It's the same as the patient leaving the hospital. And if you're all singing from the same hymn sheet, it makes it really easy to do an outsource list. If you don't have oversight and you're not really sure what the patient expectations are, and you don't have that sort of well-established communication, agreed pathways, etc., it makes it really difficult. Also, knowing what the pathways are means that if you have a blended list, so you have a few public and a few private patients, you know how to manage the different expectations with the groups of patients, because they are different. And so, as I said, I think it's all about being able to have oversight of what you're doing. And also for those who are booking patients into the public or private outsource, in-source situations, being able to reliably know that those patients are going to be operated on, and it's a suitable list for them, it again just makes such a big difference to how you do it. I mean, previously we had state patient notes being sent to private rooms, being screened, the notes then getting sent back again, patient then waiting for another 4 or 5 months, and then it happening again. And then you'll get the patient in, and if it had been outsourced to you, the patient may have actually been operated on because somebody else may have taken the outsource, or it's having oversight makes a big difference. I think the patient expectations, it's pretty much the same for everyone, or the way that I would view it is you treat pretty much all the patients the same. It's just how they get into the system and which facility is the best facility to do things. I'll always highlight as a clinician, one of my biggest fears is how you integrate training into it. And that's where, if we remove all the tonsils and septoplasties into outsourced private sector, how do the new guys learn how to do it? And I think that's, again, where having oversight as clinical directors and senior clinicians, you can at least try and provide a little bit of that balance. But again, it's just knowledge of the patients.
Laura, do you have any visibility of how Austin's thinking about contracting out some of the patients on the wait list, and particularly around some of the protocols around oversight and governance, and how the handoff of information happens in that well?
Yeah, look, to be honest, that's not something that is part of our work stream in elective surgery reform. Our external activity is separate to that and has its own sort of lead, and so I'm not really involved in that. So yeah,
no, fair enough.
Yeah, they do have set guidelines and criteria of who's appropriate to go to private and things like that, but it's not something that I'm involved with.
Yeah, fair enough. Look, what strikes me in hearing a lot of this conversation is that what's key to solving some of these challenges at a macro level is that if we've got a large number of patients that are on this surgical wait list, the preoperative function of a health service at a both system level, site level, or health network level is really critical, because that's really what's going to determine the level of risk that a patient has, the level of acuity, what pathway they belong to. And so I wonder whether the panelists can talk to how they've seen that function within the health service evolve over recent times, and because presumably if that part of the patient journey is efficient and has got good access to information, then we can make sure that more patients flow through the health service. Casey, did you want to comment on that at all?
Yeah, absolutely. So we've sort of, as Stuart was talking about that oversight of our patients, we've been able to, by implementing some digital pathways, have the oversight of those patients, understand who is truly ready for care, and we're able to do that by that health assessment that we have visibility over. We're able to automate some of those functions in terms of highlighting to our teams, what those risks are. So it certainly has improved the ability for our hospitals to assess the patients in that way. And then we can see there's a patient ready for care. If we do have a cancellation, we can identify that this patient has been assessed, and then contact that patient to sort of backfill a list perhaps. So certainly in terms of managing a wait list, having the information available in terms of pre-op assessment, and just that communication back and forth with the patient has really helped us to have improved oversight.
Great. Laura, any thoughts on that?
Yeah, so we've got workstream leads that are dedicated to digitalisation and patient communication within our unit. And they are looking at things like using a CRM, client relationship manager, as that has a patient portal function in there, and that will allow patients to have the visibility of their ready for care status, their days waiting, communicate with the surgical access office directly about any concerns. So similar to what Casey's mentioned there, that's sort of one of the tools that's being explored by that work stream, as well as we've got rolling waiting list audits where text messages are sent out to patients every 6 months, I think it is, about, are you still, you're on our waiting list, has there been a change, etc. For patients sometimes are waitlisted at multiple centres and might have had their procedure done elsewhere, and it's helped us to sort of clean up our waiting list as well in having that sort of tool. So they're the types of tools that we've been using and exploring and using as well.
Yeah, it's really interesting area. One of the projects we've been working on for the last year or two is in the pre-anaesthetic consult phase. Is that so? The traditional approach is in a public acute facility, all patients would be assessed by an anaesthetist face to face or via telehealth, and so the model that they introduce is to take the evidence-based assessment model that they were using to assess patients face to face and effectively triage patients' information through that to essentially triage patients into 2 or 3 categories. Either you need to be seen face to face because you are high acuity, you can be seen via telehealth, and or you're low enough risk based on evidence-based models to have a direct access model. And so again, what that highlighted is that one, you can for some patients streamline the process for them so they get earlier access to care. You can make better use of your scarce clinical capacity within that clinical team, but overall still apply evidence-based care to that process, but improve the throughput of patients overall. So when you think about it, you can apply that same principle to every step in the patient journey, and I think that's part of the opportunity here. What about on discharge? So we've been talking all about how patients get into surgery. Any thoughts on processes or challenges around how do we discharge patients? What are some of the barriers to discharging patients on time and some of the blockers there? So you were talking about those long stay patients. Any thoughts on some of the strategies that work there?
I think that some of it is just having that quite robust pathway. I mean, certainly for the in my world is things like the head and neck cancer patients, and we're essentially prepping them for discharge before they got admitted. Educating them if you're doing something like a laryngectomy or they needed a tracheostomy, is them having full awareness of what that entailed before they came in. Getting things like occupational health, if you knew their lifestyle would change as a result of the surgery, getting them involved in the community really, really early in the process. And that made a huge difference at the other end once discharge planning was sort of being, quote, started. It was already well underway. It was just sort of actioning the plans that you had already made. And I think that makes a big difference. And also with the more complex patients, it's often involving the wider family. And that's, again, something that we noted. I think I probably noted it more during COVID when I started doing sort of Zoom and video consults with a wider family, is the amount of extra information that they absorbed and understood about what you were doing to their relative was so much better. It just made the discharge, they were being supported by the family a lot more, and that made the discharge a lot easier. So again, I think the one of the sort of traditional methods of having the single patient in front of you, maybe with one supporting relative in clinic, and explaining what you're going to do as a surgeon, to flipping that to bringing in a much broader base, again, makes a big difference. But again, it's information, and I think the more you give to the patient, I'm always surprised at how much they absorb and that they're bought into it, because a surgery is a massive deal to an individual, and it's our day-to-day job, but actually they want to be engaged, and anything that allows them to be more engaged, I think actually works well. and for the majority of patients, you get better outcomes.
Yeah, thanks, Stuart. Look, I'm conscious of time. Casey and Laura, did you have anything you wanted to add on that discharge piece, Casey?
Really only that we are able to, again, identify those patients that we may have concerns with about discharge and sort of identify that a bit earlier. That's something that we focused on as well.
Laura, what you say?
I suppose for us, we've been looking at the information, the written information we give patients as well at the time of booking. That's been sort of reviewed throughout our process because, you know, they're completely overwhelmed sometimes with the information that they get given over the phone at the time of booking. So being really clear in the written documentation they receive as well and how they're receiving that information is something that is being looked at.
Yeah, look, a simple example we've been involved in a number of times is just, for example, for different types of procedures. If you're a day patient, have you organised someone to pick you up on at the end of the procedure? Just actually screening that as part of the pathway pre-admission actually saves a lot of the headaches post-discharge. And some of those simple things, I think, is what we're kind of coming to, is that by building in to your pathway some of that work up front tends to improve the experience for all involved on discharge as well. Look, I'm sure we could go on for another half an hour or so. It's a big topic, but really wanted to take the time to appreciate and thank you for your time, Stuart, Casey, and Laura. I think it's been a really diverse and wide-ranging conversation from the chat. If the chat's anything to go by, we've had a lot of interesting discussions on there as well. Thanks everyone who's joined us as well. We'll send out a recording of this to everyone, and thanks everyone for making the time today. Thank you, everyone.